Welcome to today's webinar, Mood Disorders and the Chronically Ill Patient. I'm Christina Cowger, licensed psychotherapist. Today we'll be discussing mood disorders and the chronically ill patient with a specific focus on inflammation. We will also be discussing novel pharmaceuticals, which may offer clues to deeper immune components to mood disorders. The key objectives in today's webinar is to begin to make the connections between inflammation and mood and anxiety disorders, disease states and mood disorders, to gain a better understanding of some of the new novel pharmacology being prescribed in behavioral medicine, and by understanding the mechanism of action of this novel pharmacology, we'll begin to also highlight those deeper immune components to mood dysregulation. And we'll also get a clinical picture through a case presentation by Dr. Sandra Schweig. Let's begin by looking at some of the statistics of chronic disease states and mood disorders. The World Health Organization predicts that by 2030, more people will suffer from depression than any other medical condition. Depression affects over 10% of the U.S. population. Approximately 40 million American adults age 18 and older, which is about 18.1% of people in this age group in a given year, have an anxiety disorder. Most people with one anxiety disorder also have another anxiety disorder. Nearly 3/4 of those with an anxiety disorders will have their first episode by age 21. Another startling statistic, antidepressant medication use has increased 400% since the 1980s, when drugs such as Prozac first hit the market, even though recent data suggests that these medications offer little, if any, benefit to people with mild to moderate depression. As we begin to take the statistics of depression and mood disorders and align them with chronic health conditions in the American population, we can begin to see that there's a strong, significant link between chronic illness, inflammation, and the increase in mood disorders. Nearly 50% of American adults have a chronic illness. 7 out of 10 deaths among Americans each year are from chronic disease, with heart disease, cancer, and stroke accounting for more than 50% of these deaths each year. Obesity, which we'll discuss further in the webinar, has become another major health concern. 1 in every 3 adults is obese, and 1 in 5 youth between the age of 6 and 19 is obese. About 1/4 of people with chronic conditions have 1 or more daily activity limitations, and arthritis is the most common cause of disability. Researchers have found that patients with autoimmune diseases were 45% more likely to have a mood disorder, and a history of infection increased the risk of a mood disorder by 62%. About 1/3 of people diagnosed with a mood disorder have been hospitalized in the past for a serious infection. The risk of inflammation increases with unhealthy lifestyle, obesity, and chronic disease. Inflammations that are hidden inside your body as a result of disease or unhealthy lifestyle do not only damage your physical body, but the research supports that they also affect your mental state by triggering depression. Mounting evidence indicates that inflammation may play a significant role in the development of depression and anxiety. Patients with depression exhibit increased inflammatory markers, and administration of cytokines and other inflammatory stimuli can induce depressive symptoms. Higher than normal blood levels of C-reactive protein, CRP, which is an indicator of an inflammatory condition, increase the risk of depression 2 to 3-fold. The risk factors of elevated immune activity include serotonin monoamine dysregulation, HPA dysregulation, white matter pathology, gray matter pathology. which all lead to mood dysregulation. Evidence has implicated elevated immune inflammatory signaling activity in the development of mood disorders, including major depressive disorder and bipolar disorder. This is supported in part by cross-sectional evidence for increased levels of pro-inflammatory cytokines and acute phase proteins during mood episodes. In addition, it has been shown in the research that adjunctive treatment with anti-inflammatory agents augment the therapeutic efficacy of many antidepressants. In considering the immune inflammatory signaling mechanism relevant to mood disorders, it is important to start to look at cytokines and depression. Cytokines are regulators of host responses to infection, immune responses, inflammation, and trauma. Cytokines have an influence on depression through the activation of the HPA axis, through the activation of neuronal serotonin transporters, and through the stimulation of indolamine 2,3 dioxygenase. The enzyme indolamine 2,3 dioxygenase is induced by pro-inflammatory cytokines and may form an important link between immune functioning and altered neurotransmission, which can result in depression. The tryptophan kynurenine pathway is comprehensively described with a focus on the evidence linking metabolite alterations to depression. Increased indolamine 2,3 dioxygenase activity may cause tryptophan depletion and increased neurotoxic metabolites. Cytokines can activate neuronal serotonin transporters. Any stimuli that enhances SERT activity might be predicted to diminish synaptic 5-HT availability and therefore increase the risk for 5-HT-related central nervous system disorders. As we consider new horizons in mood disorders, the question remains, could inflammatory changes in the brain be one of the main drivers behind our epidemic of depression? Could this also explain why many antidepressant medications often don't work for people with depression? Following is a case review with Dr. Sandra Schweig, who discusses a patient with an immune insult who is exhibiting anxiety and sleep disorders. Dr. Schweig, thank you for joining us today to talk a little bit about mood disorders and inflammation or chronic illness. One of the reasons that I was thrilled to have you have a conversation with me about this topic is because I know as a medical doctor, one of your areas especially, or your area of specialty, what you're known for is really complex cases where inflammation or virus, bacterial insults are at the root of what you're seeing in your practice. And as a psychotherapist, I often see people coming into my practice presenting with things like anxiety and sleep disorders and depression, and there's always a suspicion on my part, especially when we do the med review, and there's lots of meds added in there that have mechanisms of actions that deal with maybe neurotransmitters that deal with inflammation, and people will often complain about pain, sometimes specific and sometimes not specific. So I'm really excited and looking forward to more collaborative work with patients. And I would love today if you could share a little bit about a complex case maybe where you saw a real impact to the nervous system and the mood. Maybe somebody had Lyme, or maybe one of the PANDAS cases where you started to think and address the inflammation and notice a real significant shift in mood.
Sure, absolutely. And anytime I see a patient with mood disorders or anxiety or trouble with sleep, I'm always curious as to what the underlying triggers for that could be. And in the vast majority of cases, there are imbalances that can be addressed, analyzed, tested for, addressed, and independent of simply calling it depression and treating it with SSRI, for example. The fact is that the human organism is incredibly complex, and the interplays, for example, between the gut and the brain, or if there are hidden infections, interplays between those infections and the brain, are remarkably diverse and remarkably intense. For example, with tick-borne infections, one of the big red flags for me is somebody who has, for example, treatment-resistant depression, or treatment-resistant anxiety, or a sudden onset of an anxiety disorder or a panic disorder where before they didn't have one.
Right.
And a gentleman comes to mind, a 54-year-old man who had some significant health issues but never had an anxiety component, and then out of the blue develops this severe anxiety, shortness of breath, panic disorder, and went to his psychiatrist and was prescribed multiple different medications, antidepressants, benzodiazepine medications, with some blunting of the symptoms, but did not resolve them. And when he came to see me, I tested him, and we found a extremely high elevated titer to Babesia, Babesia microti. On the West Coast, we also see Babesia duncani. And it's well described in the literature as well as the clinical experience that Babesia as an infection can manifest with anxiety, shortness of breath, sweats, panic, etc. We began treating him, and within the first, I would say, 1 to 2 months, he's not back to perfect yet, but pretty quickly we're able to decrease his symptom load, get him off of some of the other medications that he was on, it's such a compelling thing to me because had this guy not seen somebody who had that in their back of their head about, okay, one of these infections could possibly be doing this, he would basically be going down a road of more and more psych meds.
Exactly.
And with very poor control over his symptoms.
Yeah, and it's definitely one of the impetuses for me to get the dialogue going in my own profession, and also between healthcare practitioners, because I know from my arena, we study the DSM, we're well versed in the DSM, and things that could have a biological underpinning coming from an immune insult oftentimes might be categorized, if they went down a behavioral medicine pathway, as a mood disorder or anxiety attacks, when we know that there's a deeper root cause there.
Right.
And so my hope is that, unfortunately, as people become sicker, we also need to be pushed to find more solutions, and collaborative medicine seems important.
The field which you're discussing of the crosstalk that exists between the immune system and the brain is super fascinating and super dynamic at this point in time. The research literature that looks at the status of the gut and the microbiota, the microbiome in the gut, is really exploding right now with discussions about the effects that has on the brain, and then conversely the effects that the brain has on the gut. And so there's this crosstalk, this bidirectional flow of information. And even if someone is presenting with a purely psychiatric disorder, it's been clearly shown that any work you do on the gut or on the gut immune system or on balancing that aspect of the body has really profound effects on the brain.
Absolutely. So I think as we progress forward in medicine, the walls might have to come down between immunology and
Right.
behavioral medicine and
Intermingled.
Exactly. And again, in the world that I'm coming at it from is I'm seeing all of these new novel drug approaches, which again, they see they're working and they know there's an immunological component, but the collaboration I think is still at only the threshold of I think where it's going to go in the next 5 or 10 years.
Yeah, and we have to resist the urge to try to find that one drug that is going to quote unquote fix it. Because for some patients, for some subset, it'll help. But really, the more broadly we look and the more different body systems we work on simultaneously, the better things will do.
Absolutely. Well, thank you for the great work you're doing with patients, Dr. Schweig, and thank you for joining us today.
It's been my pleasure. Thank you.
Thanks. As we saw in the earlier slides, there's an epidemic in chronic illness in the United States, as well as an epidemic in both depression and anxiety disorders. Dr. Schweig did a wonderful job of presenting a case. And again, it brings us back to the question of could inflammatory changes in the brain be one of the main drivers behind our epidemic of depression? It also helps to explain and highlight why antidepressant medications often don't work as the only consideration when treating a mood disorder. As we consider new horizons in mood disorders, it's important to not only consider the research and nutraceuticals or pharmaceuticals, but it's important to focus on lifestyle considerations. In the following slides, we're going to look at stress and the inflammatory response. As well, we're going to look at obesity and the inflammation and inflammatory response in the body. There are stresses that we have control over, and there are stresses in life that we don't have control over. But one thing we do know is that stress weakens immunity, it depletes the nervous system, and it disrupts the body's hormonal balance. Stress is a wide-ranging sequence of physiological events involving virtually every organ in the body. The emotional centers in the brain that process stressful stimuli are directly linked with the nervous system, the hormone system, and the immune system. Chronic stress, therefore, has a profoundly negative effect on overall health. Findings have implicated the hypothalamic pituitary adrenal HPA axis dysregulation in the pathophysiology of mood disorders, and evidence suggests that pro-inflammatory cytokines alter HPA axis activity and reactivity. As you can see from this slide, stress, some examples: early adversity, interpersonal conflicts, social isolation, to name a few, has a direct effect on the corticotropin-releasing hormone, CRH, which plays a central role in the adaptation to stress. CRH serves as the main regulating hormone of the HPA axis, which is activated within seconds after exposure to acute stress. The functioning of CRH is a delicate equilibrium which can be permanently disturbed by early experiences of abuse, leading to psychopathology in adulthood. There is much research emerging now on CRH and HPA axis abnormalities in major depression and other psychiatric disorders. This rapidly accumulating evidence is beginning to change our understanding of psychopathology and may challenge the established classification of psychiatric disorders. Another major lifestyle consideration is obesity as it relates to depression, anxiety, and inflammation. One primary source of inflammation and depression appears to be adiposity. Adipose tissue is a rich source of inflammatory factors, including chemokines and cytokines, and a bidirectional relationship between adiposity and depression has been revealed in the literature. Adiposity is associated with the development of depression. This slide represents the vicious cycle between two conditions, depression and adiposity, both centering around inflammation. Weight loss is associated with the reduction in the macrophage infiltration of white adipose tissue and an improvement of the inflammatory profile of gene expression. We have now touched on chronic illness, inflammation, stress, and obesity as it relates to mood disorders and anxiety. Now we're going to touch on genetic variability and epigenetics. Genetic variability. Research data from family, twin, and adoption studies show that psychiatric disorders such as depression, schizophrenia, anxiety, and bipolar disorders are complex disorders that typically arise as a result of the combined effects of genetic and environmental factors. Epigenetics. Epigenetics is the study of changes in your genes caused by mechanisms other than changes in the underlying DNA sequence. Epigenetic processes do not change the DNA sequence, but tell your genes to switch on or off like a light switch. Epigenetics has shown that genes can be turned on and off by experience and environment. Many genetic studies in the past completely ignored the science of epigenetics, which is how the environment actually turns certain genes on or off. One example would be studies that actually show though certain genes might predispose someone to addiction, if they grew up in a nurturing environment, those genes may remain inactive. The epigenetic hypothesis of psychopathology, such as depression or anxiety disorders, states that faulty expression of important genes in the brain are occurring because of abnormal modification to the DNA sequence. These abnormal modifications may be randomly occurring or may be driven by environmental effects. For example, certain foods, toxic chemicals can change the methylation pattern of our DNA. Traumatic events in the early life or adulthood may potentially alter our DNA methylation pattern and induce abnormal brain gene expression and ultimately depression and other mood disorders. One area that's rapidly evolving in behavioral medicine is medication and epigenetics. Currently, there are dozens of research programs that are testing new drugs which may target the enzymes that modify our DNA and abnormal epigenetic patterns. The hope is that these new drugs may be able to reset the proper expression of multiple genes that are involved in depression and psychopathologies, including serotonin. The three main approaches that epigenetic therapeutics in psychiatry are taking include 1. Silencing genes by promoting methylation, 2. Activating genes by blocking deacetylation, and stopping genes from being translated into proteins by interfering with their RNA. It's a mouthful. While much of this work is still in its early stages, this approach is based on the idea that if mental illnesses are caused by the expression of risk genes that make altered proteins, or by the expression of normal genes that turn them into risk genes by making normal proteins but at the wrong time, then maybe silencing risk genes or activating compensatory genes would treat or even possibly prevent mental illness. Another key area of research is related to metabolic syndrome and mood disorders. Depression is a common comorbidity in individuals with metabolic syndrome. Inflammatory mechanisms have been suggested to be involved in depression and metabolic syndrome. C-reactive protein, a reactant of systemic inflammation, has been found to be independently associated with metabolic syndrome and depression. Metabolic syndrome also has some strong correlations with bipolar disorder. Bipolar disorder patients exhibit a high prevalence of obesity and metabolic syndrome. Lifetime and current prevalence rates of asthma are elevated in patients with mood disorders, particularly bipolar. These data suggest that elevated immune inflammatory signaling may be associated with prominent medical comorbidities frequently observed in major depressive disorder and bipolar patients. Before we move on to the novel pharmaceuticals, let's review standard meds in behavioral medicine. We have the tricyclic antidepressants, TCAs, which include drugs like Elavil. TCAs work by slowing the rate at which neurotransmitters re-enter brain cells. Another class are the monoamine oxidase inhibitors, the MAOIs. The third are lithium salts. One of the largest class is the selective serotonin reuptake inhibitors, the SSRIs, which include drugs like Prozac, Paxil, Zoloft, and Lexapro, to name a few. And then the serotonin norepinephrine reuptake inhibitors, the SNRIs, which include drugs like Effexor and Cymbalta. I included benzodiazepine in the webinar because they remain among the most frequently recommended medications. In 2008, 112 million prescriptions were filled for benzodiazepine class drugs. I included the benzodiazepine category because of its effects on GABA. Research suggests that the immune system needs GABA to function properly, which may explain why it is common to have frequent infections and a compromised immune system after long-term use of benzodiazepines or in the withdrawal process. With continued use of benzodiazepines, the calming effect of GABA is diminished, while the excitatory neurotransmitter glutamate is increased. Glutamate is an excitatory neurotransmitter, and GABA is what counters this action. It has been proposed that diazepam, a benzodiazepine, may cause long-lasting changes to the GABA-A receptors, with the resultant long-lasting disturbances to behavior, endocrine function, and immune function. As we move into new models and novel pharmaceuticals for addressing depression and anxiety disorders, we need to consider that alongside the monoamine hypothesis include important considerations such as excitotoxicity, neuroplasticity, the neuroinflammatory, metabolic, and cellular redox, i.e. oxidative stress to the cells, models in behavioral health. Novel pharmaceuticals. Preliminary evidence suggests that adjunctive treatment with anti-inflammatory agents augment the therapeutic efficacy of mood-stabilizing medications. Emerging clinical evidence suggests that mood-stabilizing medications downregulate pro-inflammatory signaling pathways in bipolar patients. There is much research as it relates to bipolar depression and the abnormal activation in function of the inflammatory network, which has been implicated as a causative and consequential in bipolar depression symptomology. Elevated concentrations of pro-inflammatory cytokines have been implicated in bipolar depression and mania. In obsessive-compulsive disorders, OCD, increasing evidence indicates that abnormal levels of the neurotransmitter glutamate contributes to OCD and may be a fruitful target for new therapies. Glutamate is widely distributed in the CNS. It's involved in fast synaptic transmission and also in plasticity and higher cognitive functions. Glutamate can also induce neurotoxicity, and it's been implicated as a potential contributor to the pathogenesis of several CNS neurodegenerative disorders such as Alzheimer's disease. The role of glutamate in anxiety disorders is becoming more widely recognized. Recent data from MRI studies provide an additional link between the glutamate system and anxiety. Human clinical drug trials have demonstrated the efficacy of glutamatergic drugs for obsessive compulsive disorders, post-traumatic stress disorder, generalized anxiety disorder, and social phobias. Several glutamate receptors and glutamate transporters have been extensively described in the central nervous system, where they respectively mediate glutamate effects and regulate extracellular glutamate levels. Recent studies have shown that glutamate not only has a role as a neurotransmitter, but also as an important immunomodulator. One key drug that's had an emergence in the novel psychopharmacology world is Lamictal. Lamictal historically was used for epilepsy and seizure disorders. Lamictal has been more widely prescribed for conditions such as bipolar disorder. Lamictal reduces release of glutamate and appears central in its therapeutic effect. So its influence on glutamate is one of its key effects. Lamictal reduces neuronal hyperexcitability and also modifies synaptic plasticity. Lamictal reduces excessive central neurotransmitter release. Indirectly, this could regulate intracellular and intracellular signaling in critical regions of the limbic forebrain where manic hyperactivity may occur, and thus be responsible for Lamictal's mood-stabilizing properties. Another drug, Rilutech, which has been marketed since 1996 for Lou Gehrig's disease, ALS, is approved for other medical conditions and is available for research and clinical use. This is another drug that affects glutamate levels. In an initial open-label study in 2005 and a case series in 2008, it was found that approximately half of the severely ill treatment-refractory patients who had not responded to other treatments improved significantly when Rilutech was added to their SSRIs. Research at the National Institute of Mental Health have found similar results using this drug in children with OCD. Memantine, or Namenda. Another drug that is available and affects how neurons respond to glutamate is memantine, or Namenda. Several case reports and 2 recent open-label case series suggest that the addition of memantine to standard medication therapy has had a benefit with both children and adults with OCD. We've just discussed 3 drugs that target glutamate when dealing with mood disorders. I want to touch on another drug, Remicade, which was initially used as an anti-inflammatory drug. Remicade works by binding to TNF-alpha, which is a chemical messenger cytokine and a key part of the autoimmune reaction. In rheumatoid arthritis, this drug seemed to work by preventing TNF-A from binding to its receptor in the cell. This drug specifically targets inflammation and has been used successfully to treat depression, providing further support for the depression inflammatory theory. 62% of depressed people with high blood levels of C-reactive protein had a reduction in their depression while taking Remicade. As we consider new horizons in mood disorders, it seems clear from the research that we need to consider all systems in the body when looking at and treating a mood disorder. I come back to our question, could inflammatory changes in the brain be one of the main drivers behind our epidemic of depression? And can this explain why first-line antidepressant medications often don't work for people with depression? In conclusion, It's clear that we need to consider inflammation, both seen and hidden, as a key in mood disorders. We also see that lifestyle and stress have significant inflammations on mood disorders. We were introduced to epigenetic developments, both in understanding how our environment can impact our disease state and health state, and also epigenetic developments in medications. And we were introduced to old drugs with new novel application, giving us clues to systemic issues. Thank you for joining us today. Join us again for our next webinar.